Okay. Good evening, everyone. I'm Rajiv, marketing manager for Abbott Heart Failure Team, India. On behalf of Abbott, we sincerely appreciate all the doctors and the healthcare associates for their commitment towards community health during this constrained situation. We welcome all the delegates to this interesting webinar today on short-term mechanical circulatory support and management of cardiogenic shock, a case-based approach by two of the eminent speakers. We have Dr. Ravi Shankar Shetty, who is a senior and chief consultant cardiothoracic surgeon and transplant surgeon at MS Ramaya Narayan Hrudayalaya, Bangalore. We have also with us Dr. U. Nagmal, who is a senior consultant and associate professor, Department of Cardiology at MS Ramaya, Bangalore. So we have two topics today, and the first topic would be on the short-term mechanical circulatory support by Dr. Ravi Shetty. Now, I would like to invite Dr. Ravi Shetty for the first topic. Thank you.
Uh, Thank you. Good evening, colleagues. I'd like to thank Abbott for organizing this webinar. And they had asked us to actually visit different hospitals to train the doctors. But then, in the situation of COVID, they've asked us to do a webinar, and I'm very pleased to be part of it. So let's start off with the topic of temporary mechanical circulatory supports. Temporary mechanical circulatory support refers to a group of devices generally used for less than 30 days to maintain adequate organ perfusion in heart failure. Heart failure in any condition, it can be due to cardiogenic shock like post-MI or its related complications like post-MI MR, VSD, or even after stenting, the heart is, the BP is not maintained, they're in low cardiac output. So then to keep the patient alive, we need such devices so that the heart recovers, or in acute decompensated heart failure, acute myocarditis. We are seeing more and more of viral myocarditis now. And acute rejection post-transplant, or even after transplant, we usually see the RV failing. So that time we need some form of temporary mechanical support. We usually, most of the time, we use ECMO in these situations post-transplant. Or in high-risk interventions, we are seeing I heard about 40 cases in India. They've used for percutaneous coronary interventions and ventricular tachycardia and bridge to LVAD or transplant. These are situations where the patient is not fit for LVAD or transplant, or we don't know how the patient is. For example, his liver enzymes or his kidney markers are elevated. So we don't know whether he's fit for a transplant or is in cachexia. So we can't straight away do a transplant or put in a LVAD with high PA pressures. So those are situations when temporary circulatory supports are used, especially Centrimag in these situations are helpful where the lung is okay, but then we have to support the right or left side of the heart, and in RV failure. So you can see there are multiple devices available. This is mainly because there is no, the ideal device is not available with us. Each has its own advantages and disadvantages. The ideal device would be one which gives, can keep the patient mobile, which is more durable. Then it unloads the LV better, and the flow dynamics are the best, and they are very hemocompatible, and such things. And the cost also makes a big difference. So the ideal one is not available, but we can select the near ideal one, which is to our system, which we are happy with. So these are some of the devices. IABP is available in India. See, it's again classified into percutaneous and through invasive approach. Percutaneous short-term devices are IABP Impella, which are available in our country, and ECMO, tandem heart, pulse cath, and other things are not available as yet. So these are the three available in India, and most of you have used IABP and ECMO. Impella, very few have been used now in high-risk interventions like ventricular tachycardia or stenting. They're using now slowly. And next is Centrimag, which is very commonly used in, especially in cardiac failure units. And Biomed BVS 5000 is not yet available. This is again a pulsatile device to support biventricular support. These need a little more invasive sternotomy approach to install. So these are some of the percutaneous devices and the advantages of each. You can see intra-aortic balloon pump, it gives increase the cardiac output by only by 0.5 liters, and ventricular preload and afterload is decreased slightly. It is not of much use, and there's increase in mean arterial pressure, and the main advantage of this is it increases the coronary perfusion. Impella, again, there are about three types. Impella 2.5, that is 2.5 liters flow, it increases. CP is about 3.5 and 5. So there are three. Impella 2.5 and CP can be percutaneous, but Impella 5 has to be done by a cut down. It is because it's a 21 French cannula. The advantage of this is, as all of these devices, it decreases the preload, but as you can see on the screen, afterload is not increased in Impella when you put it percutaneous. So this is a great advantage which helps the heart recover after it has failed. So other devices, even ECMO or a tandem heart, increases the afterload, which is counterproductive for the failing heart. And the mean arterial pressure is increased in all these devices. ECMO increases the cardiac output by 6 liters and tandem heart by 5 liters. So tandem heart is not available. And now coming to Centrimag, this is the other one which is usually put through sternotomy. It can give an increase of cardiac in a flow of about 10 liters per minute. The preload is decreased. The afterload also is not increased because it is put through a central cannulation, and the mean arterial pressure also increased. And this pump is more hemocompatible and less chance of thrombosis compared to others, and it is approved by FDA for about 30 days. So that's the advantage of Centrimag or other pumps. So now, when do we put a temporary device and when do we go in for LVAD or a transplant? In stage 5 and 6, we'll have to do some. We'll have to see how the patient is fit. If he's fit, stage 5, we can go in for a LVAD or a transplant depending on the patient's condition and his fitness and other factors, which I won't go into detail today. And but stage 1 and 2 is almost a contraindication, and the results are very poor going in for LVAD or a transplant directly, because we don't know the patient condition. He's very sick, so the results are not good, and both the transplant and the durable VADs will fail. So these are the situations where the temporary devices will help. So patient is cardiogenic shock, supposing post MI, then you will have to think of one or the other device which is in your unit and which is the patient can afford, and which is compatible and helpful. It's for us to decide and inform the patient and take it forward. So level 1 and 2, these are the patients who we think of putting a temporary circulatory support when the inotropes fail. So what are the contraindications for these devices? There is nothing absolute contraindications, like document irreversible neurological damage is there. Then we'll have to not put in these devices because it's no point. And malignancy, which already is spread, and bleeding disorders or platelet count is less, or if you think of the severe infection because of which there is DIC or reduced platelet count, then it is contraindicated. Severe peripheral vascular disease is a contraindication for peripheral percutaneous devices. Again, a central device can be used. Contraindications for left ventricular assist devices, again, some are, for example, thrombus in LA or LV. Thrombus in LA is a contraindication for tandem heart. Thrombus in LV is a contraindication for Impella. So all the devices, so we have to see it's per, you have to see the patient and then decide which is the device optimal for him. So if there is a thrombus, there is a risk of embolization. If there's severe or moderate AR, IABP can't be used. And the same way, Impella is a mild to moderate contraindication. So we'll have to, and again, peripheral. So we'll have to see some form of unloading the LV because of AR. The LV will be distended. So then we have to think of some through a sternotomy, or how are we going to unload this LV because it keeps getting filled, and then there won't be rest for the myocardium. It won't recover. If you're thinking of recovery, it won't recover. So atrial or ventricular septal defects or mitral stenosis, these are contraindicated. Supposing we put an Impella or a tandem heart, the LV is unloaded. What happens then? There's right to left shunting, or if there's a mitral stenosis, you can't. There's no proper LV filling. So we have to think of all this and then decide on a particular device which is suitable for that particular patient. So this is again the same slide. You can see the different sheet sizes for IABP. It's percutaneous 7 to 8 French. Usually there's no problem if you put in without percutaneously. Impella 2.5 and CP can be put percutaneous 5. As I told you, you need to cut down. And ECMO, we'll have to think of ECMO or tandem heart or Impella 5. We'll have to do some form of peripheral perfusion by putting in a H French cannula distally so that the limb is perfused. And these are the common complications of peripheral limb ischemia and bleeding and hemolysis, etc. So this is one of this is how the IABP works. Systolic unloading, therefore it's easy on the heart. So, and diastolic augmentation, therefore increasing the coronary perfusion. This is one of our patients, IABP we use so commonly, and we take it for granted. We had told one of our residents to remove in the evening. The balloon had ruptured, and you can see down the fourth. It becomes like a stone, and the edges are very sharp here. So they tried to pull it. Ioto-iliac junction, there was a tear. Then we had to open and repair it. So we can't take any of this device, however simple it is, for granted. This is a movie of axial flow pump, that is Impella. It goes across the aortic valve into the LV. The inflow cannula is in the LV. It sucks out blood and releases in the ascending aorta. So this unloads the ventricle, increases the cardiac output, increases the end organ perfusion. So this is a good device, but it's very expensive. It costs about 18 to 20 lakhs, and it can be used for a week to 10 days. Maximum they've used up to 2 weeks. This is a Impella RV for right ventricular failure, where the inflow cannula is in the IVC, the blood is sucked out, and it is put into the PA. So this both can be done percutaneously, and this is more commonly used during intervention procedures nowadays. But it's not very common in our country because of the high cost. This is a picture of VA ECMO, which is again a most common circulatory device used in our country. Go back to you can see here it has an oxygenator, so it supports both the heart and the lungs here. So this is the advantage of this device over all other devices, that it can support both the heart and the lung. Again, it has it can be used peripherally or centrally depending on the patient and your comfort and the availability of the surgeon. So some of the important points to remember while putting ECMO peripherally is, first thing is we'll have to put a we'll have to remember something called Herwickan syndrome, where when you pump blood from the distal femoral artery, so as you can see here, I'm playing this video. The blood is pumped up to the ascending aorta. It might not supply the vessels of the brain because the LV is also ejecting. So we have to keep a pulse oximeter on the right hand to see whether it's desaturating. So then we'll have to adjust the ventilator so that the lungs are working well and the LV, whatever blood LV is ejecting, is the saturation is good, so the brain doesn't get damaged. So it's very important to see the right hand ABG or keep a pulse oximeter on the right hand. This is a practical point where some of us miss it after putting. And other thing is always put in a distal cannula first if you're putting a peripheral ECMO. Distal arterial cannula first, about 8 French arterial cannula, and then put a proximal cannula perfusing the body. Otherwise, you won't get a distal access. So put in a distal cannula through a wire, you connect it to the proximal cannula, so the blood is perfusing the distal limb. Then other thing is, as I told you earlier, what happens in ECMO when you put a peripheral ECMO, the blood is being pushed against the heart. So the heart doesn't get unloaded properly and it is acting, it is counterproductive. So somehow we have to empty the heart. Either if you put a percutaneous, if the heart is about, your heart beat is not beating, EF is okay, and heart is able to pump a little, the LV will improve. The heart is very bad, then we'll have to do some form of venting. Ideally, in an percutaneous, you can, cardiologist can do a transeptal, you can create an ASD, pass in a guide wire and create a ASD. So there's venting from LA to RA. Or we have to do through a mini thoracotomy, vent in the LA, in the LV or LV apex. Or what is a ECPella is you put in an impella with an ECMO. Again, all this for our patients, I think it's not practical because of the cost of an impella going up to 20 lakhs. So transeptal puncture will be an ideal thing, or you can ask your surgeon to put and vent through the LVX. A mini thoracotomy, a small incision, I'll show you later, that can be done. So otherwise the heart won't recover and there'll be rotation of blood in the LV and even a clot can form. So these are the important things to remember in a ECMO. So this is a movie of a tandem arc where the guide wires pass from the femoral vein across the septum to the LA, and the ASD is created, and a 21 French sidewall cannula is passed into the LA. So this is done to unload the LV, and the centrifugal pump is there. The blood comes to the pump, goes from the femoral artery, and again pumps the body to oxygenate the end organs, to perfuse the end organs. So this is how it unloads the heart. So this is not available in India. Now the Centrimag, which is very commonly used and even in our unit, this is a magnetically levated pump, but blood is taken from the venous system and pumped into the arterial system. This is a very user-friendly pump compared to all other pumps. Even the ECMO pump, which is a rota pump, which is a centrifugal pump. This is a better pump. It is more hemocompatible. There are no bearings, and so it causes less trauma to blood, and it can be used for a longer time. But the only disadvantage is we'll have to do a sternotomy, and it might not be practical in acute MI setting where you've given all the toxins where it might bleed. In this situation, ideally doing a sternotomy and putting Centrimag might not be very practical because the patient might bleed a lot. Otherwise, in cardiac failure situation where the patient is not yet fit for transplant or who's going to die waiting for a transplant, this in our unit has helped us. This is how it works. If you are putting a BiVAD, RA cannula is put and a PA cannula is put. So that's how you bypass the RV. Blood is taken out from the RA, goes to the Centrimag pump. It is pumped up into the PA, And here we are seeing a LA cannula. It can be you put a cannula in LV apex or LA, depending on the patient's condition. Put an LA cannula, blood is drawn out and goes into the ascending aorta. So this way, the heart is completely unloaded, and you're bypassing both the right and left ventricle. This is a picture of an LV cannula. The technical details, if you want, I can tell you later. I won't go into it now. This is one of the biggest studies of Centrimag. This is from collected all over the world from 2003 to 2012. 53 publications. The data was taken with 999 patients, and 72% of the study Centrimag was used as a VAD, that is without an oxygenator, and in about 25% with ECMO. So a Centrimag pump can be used as in the ECMO circuit. Instead of using ECMO pump, we use a Centrimag pump. The advantage is it is more hemocompatible, and the pump is more user friendly, and with less rotations, you can give more flows. That is the advantage of a Centrimag pump, and it lasts for a longer time. The mean duration in this study was the VAD was for 25 days in pre-cardiotomy group, and about 11 days in post-cardiac surgery group for cardiogenic shock, and 8.8 days or 9 days for post-transplant group or rejected after transplant group. So survival on support was 82% for patients for VAD, only VAD support without ECMO. That is only for the LV or RV support in cardiogenic shock, and 63% for VAD post pre-cardiotomy. It was 82% survival, and post cardiac surgery, it can be any form of cardiac, it was 62% survival, and post cardiac transplant because of RV failure or LV failure, it was about 83% survival. Post-transplant and post-LVAD failure. So what happens in post-transplant? Usually the LV is good, the RV fails. Even in the post-VAD, when you put a VAD into the LV, because of sudden unloading of the LV, there's increased return of blood to the RV, and the septal deviation, the RV fails, and the PA pressure is still high because we are on bypass machine. So it takes some time for the RV to recover. So then we'll have to put some form of temporary support to support the RV. That time a Centrimag is very useful. This is one of the newer articles. It's called by Takeda and Cleveland Clinic. They saw the disadvantage of a peripheral ECMO, and for which in Intermax patients with Intermax 1 and 2, they got very good results by using a Centrimag in form of ECMO. That is what they did is they put in a cannula through the IVC to drain the right side of the heart, and through a Y connector, a mini thoracotomy was done, a small incision. When you do a thoracotomy in the 5th or 6th intercostal space, a very small incision, maybe 3 inches, and open the pericardium, the apex of the LV just pops out. It's a very simple procedure. You take the purse strings here, put in a cannula. So this is how you're unloading the LV. So you're unloaded the right side of the heart with the venous cannula, unloaded the LV with the left cannula. So through a Y connector, it goes into a pump. From the pump, because you're taking deoxygenated blood, you will have to put in an ECMO. Even if the lung is working fine, you will have to put in an oxygenator because you're taking deoxygenated blood. Put in a cannula, about 80% of the blood will be coming through this cannula into the pump and then to the oxygenator. And then through the axillary, they put a graft to the axillary artery, again a small incision, and it is pumped it back into the patient. What they did is after repeated echo and ABG, once the lactate came down, acidosis came down. As I told you, it's in cardiogenic shock and stage 1 and 2, Intermax stage 1 and 2. So when the ABG is improved and patient looked improved, they extubated the patient. Then slowly they clamped the venous line and only had the LV line. So this line is clamped, only the LV is unloaded, and some blood. That means the RV is functioning well. If the heart works well with clamping of the venous line, blood goes through the RV to the PA, so the LV is working well. So they kept the patient on just an LVAD, one pump. So if they felt the RV is not doing well, RV is not able to take the load, they again reconnected this venous cannula and then thought of doing a transplant for this patient. If the RV was doing well, they just kept him on LVAD and tried to see if the heart has improved. If the patient did well, they removed them off the device. If the patient was not doing well in spite of this for a few days, then they thought of putting an LVAD. So with this, they had an excellent result. There are two papers on this. Takeda from Cleveland Clinic. Takeda et al. So this is, I think, this is going to be the future for us here also, wherein we don't know what's happening, how the right heart is, how the left heart is. Patient is very sick. In our clinical practice, we see patient come for a transplant or a VAD only when they're intermax 1 or 2. Till they're doing well, they're not referred or they don't want any form of procedure. So this will unload the left ventricle and you have put a peripheral venous cannula and a peripheral arterial cannula. By putting an axillary cannula, you're not putting more pressure on the LV also, and by putting an cannula in the LV apex, the LV is going to get vented properly. So these are the other studies, with temporary circulatory support, where all the studies have been discontinued because of lack of patients or small number. They're not able to come to a conclusion in spite of so many studies. So I'll talk about few studies. This is a shock trial, IABP in this earlier study in fibrinolyzed patient in hospital. 1 year mortality it showed was improved with IABP in fibrinolyzed patient. IABP shock 2 trial, IABP versus no IABP in cardiogenic shock, secondary to acute MI undergoing PCI. No difference in mortality, length of stay or hemodynamic stability was seen. CRISP AMI trial, IABP or no IABP before reperfusion in anterior STEMI MI resulted no reduction in scar infarct size, that is on MRI in patients with IABP. Because of all these studies, the AACC and AHA and European Heart Society downgraded IABP from class 1 to class 2A and 2B. In European Society, it's 2B respectively. So IABP has been downgraded now. An ISHA shock trial, MI with cardiogenic shock, IABP versus no IABP, IABP versus Impella. Impella demonstrated improved cardiac output and cardiac index, but no significant difference in hospital and 2 years mortality after even putting an Impella. So with Impella 5, post-cardiotomy, that is post-cardiac surgery, cardiogenic shock, number of patients is 29, 58% survival to discharge. Usually what happens in these sick patients who you put ECMO or any of these patients, we see in cardiogenic shock, if you don't do any of these devices, which is appropriate, they're going to die. The survival is not going to be, more than 50-60%. It's not that when you put an ECMO or you put a CentriMag, any miracle is going to happen. But otherwise, these patients would have died. So about 50-60% are going to survive with these devices. The key is to use the device as early as possible and not delay putting in this device when the end organs are really bad and patient is already at the end stage, and that time the results deteriorate. This is high risk PCI where Impella was the feasibility. Impella was used in Protect 1 and Protect 2 study. Periprocedural support with Impella 2.5 versus IABP in 452 patients were compared with EF of 24%. Impella 2.5, that is 2.5 liters flow, provided a superior hemodynamics, that is cardiac output and index, but there's no difference in the end. So even in ventricular tachycardia, they have used, what they did is they saw the saturation, but saturation at the end with the saturation was
Sir, in the meanwhile, I think there are a couple of questions. If before we get the laptop charged, I think I'll just ask one question. This is to Dr. Nagmale. So, in what setting Centrimag is better than ECMO?
It is for me.
Yes, sir. In what setting Centrimag is better than ECMO?
Can you repeat the question?
In what setting
Okay.
Centrimag is better than ECMO?
Okay. So the Centrimag and ECMO is used for different purpose. So ECMO is a short-term circulatory support, and Centrimag is medium-term circulatory support. So if I put a VA ECMO, I can't keep more than 10 days. Then they'll start having a lot of complications. Usually hemolysis, infection, bleeding, a lot of complications. That's the reason we use medium-term, that is with Centrimag. Other is if I want a biventricular support, then the Centrimag is
No, Nagmale just started. No?
so.
Sir, we are just taking one question, sir.
Okay. Then I'll finish it off.
Yeah. Sir, please.
Okay, I'll come. Okay.
So the Centrimag is better when I require biventricular support. So I'll show you a few cases after this presentation. Then you understand.
Can you hear me?
We decide between ECMO and Centrimag. So only thing is ECMO you can initiate little quickly. So if you want to bridge the patient is crashing, a patient is arrested, then you can't do that. So we have to put ECMO to this patient, and later you can consider forward if you require longer period. And if patient has got biventricular failure, then it's difficult to use ECMO. Even if you put ECMO, it will be very short term. So if I require for a longer period, suppose your patient has to undergo transplant, then better to put Centrimag, because we can keep the patient for a longer period, and we can mobilize the patient, we can improve his nutrition, then do transplant. So they're both requirement indications are different. Basically.
Thank you. Dr. Ravi Shetty, you can please.
Yeah, I'll just conclude. Yeah, this is a slide showing about MCS support for for transplant patients. Number 6,829 patients required short-term MCS. That is LVADs, percutaneous VADs, ECMO, temporary VADs or BiVAD or only LVAD. So you can see with ECMO the results are bad here, because usually these are acute cases. You put in near arrest situations and which require biventricular support. So as Nagmale just told you, in acute situations they might have put it and done an emergency transplant. So see, probably that is one of the reasons. Apart from other donor age, donor male to female recipient mismatch, all these factors also make a difference. But 1 year survival with different VADs prior to post-transplant was this with different VAD supports. So this is our experience with ECMO. We have done 39 in the past 2 years. VV ECMO 6 and VA ECMO 33. The survival was about 57-58%. In that we have put 2 VADs, that's Centrimag. It's not ECMO, Centrimag. One survived without a transplant, so the survival was 50%. We explanted. One died on VAD. This is Centrimag. And this is just LVAD. And most of the ECMOs have been peripheral, 13 central, 26 peripheral ECMOs. And post-transplant, this is again, we have put ECMO. This post-transplant, out of the 33 cases now we have done, we have put for 7 cases we had to put on ECMO. And mostly these were all the sick cases and who were probably on VAD post-transplant. So we had to, before doing transplant, we have put 7 patients on BiVAD support, that is Centrimag, both LV and RV support. Survival was 4 cases. And in this 4, out of the 7 who need ECMO post-transplant, 4 were on BiVAD support, which shows there are very sick cases who have come very late to the hospital also. This is the first case we did long back about 4-5 years ago. He was on BioVet support and we did transplant. This is one of the cases who was on BioVet support for 218 days. That is, he was on Centrimac for 218 days. This is probably the highest in the world anyone has been. These situations occur in our country because he came late. He was a near arrest situation, and we had to put him on BioVet and support him. And it delayed. We were hoping he was O positive. It got delayed. We didn't get a heart, so he was on support for 218 days. These are all again Centrimac supports. This is one of our patients who came from UP. He had his creatinine had increased. He was so sick that he couldn't come in a commercial flight. He had to take up private air ambulance and come to our center. And he wanted a transplant immediately, but he was not fit because his PA pressure was high, his creatinine and other parameters were not optimal for a transplant. So then we put him on a BioVet for 23 days and did a transplant successfully. There's one more patient. He came, young guy, maybe 18 or 20 years. He came and he had ventricular fibrillation, like cardiac arrest. So we thought, we didn't know what the situation was. We did a sonography, we put a BioVet support, and but his heart recovered after a week. And this is one more patient who was put on LVAD, who was arrested, revived, and put on LVAD, whose heart recovered, and then fibrillator was put and discharged. This is just a few things showing a peripheral cannulation. I won't go into the details of this. This is actually showing a big incision, but it's very, very small. It is enlarged femoral artery cannulation. This is a mini thoracotomy where you can see the LV apex. So this is actually not a LV venting or a LVAD put through the apex. This is actually a mini thoracotomy for CABG which we have done. So it's such a small. I just showed this picture so that it's such a small incision you can do an LV apex venting. So if you want to unload the LV with a small incision with the peripheral cannula, this can be done. So to conclude, in our system, which gives priority to patients with a temporary device. So if you want to do a transplant, if you're on ECMO, you get the priority, ECMO, IABP also. So more and more durable, more and more patients are going to be on temporary devices if there's an indication. India, the cost of the devices plays a major role in selection of the device. So we have to see which is appropriate for apart from clinically appropriate, the cost also, and the center which you are. And most of the patients require temporary succors are critically ill, but an effort must be made to make a decision early as possible. This is the ideal. Patients survive only when you make an early decision prior to cash and burn situation. And there must be always an exit strategy. Like you put in a VAD and or ECMO and then don't think what to do next. Do you know, is the heart going to recover? Or are you planning for a transplant or a VAD? That has to be the thing. Once sometimes a situation occurs like we put in a LVAD Centrimac for a patient, and after she was sitting and walking around, she didn't want a transplant. Luckily, her heart recovered. So we should not be in such situations. Thank you all for listening to me. Thank you. If there's any questions, I can take it after Dr. Nagmalesh's presentation. Thank you.
Thank you much, Dr. Ravi. Now, I would request Dr. Nagmalesh to share his presentation on cardiogenic shock. Yes, sir. Yeah.
It's okay now? Is it okay?
Yes. Yeah, perfect, sir.
Yeah.
Okay, Raju, I can start.
Yes, sir. Yeah, we can.
Okay. So, good evening, everybody. So far, you're listening to Dr. Ravi Shetty about different devices. So, we should know which one to use in which situation. That's very important for survival of your patient. in managing cardiogenic shock. So basically, you have a very bad profile cardiogenic shock. The survival is very bad. That you have to choose right device, thinking about what is the plan for this patient in long term. So before I have two patients, two cases I can present to you. So first, before going into a few slides, I'll show you about the heart failure. What is advanced heart failure or refractory heart failure, where we use all these devices? The condition is considered advanced when heart failure therapies and symptoms management strategies no longer work. So you've done everything possible, and you started inotrope, you've given diuretics, everything you have done, and this nothing is working. Then only you call it as advanced heart failure. So if you see ACCHA stages of heart failure, so you have high risk for developing heart failure, but no structural heart disease like diabetes, hypertension, like that. A structural heart disease, but no symptoms like LVH, for example. And symptomatic heart failure. This is what you get in a hospital regularly, the symptomatic heart failure. The last D is a refractory heart failure, where all this therapy, whatever you use regularly, is not working, as I keep coming back to hospital with heart failure. So once we say refractory heart failure, it requires specialized interventions and INTERMAC classification. So Dr. Ravi keep telling you about the INTERMAC classification. I thought I'll just tell you if you're not familiar with this. So this is INTERMAC profile. One is a critical cardiogenic shock, where patient is life-threatening hypotension despite rapidly escalating inotropic support. Critical organ hypoperfusion, often confirmed by worsening acidosis, lactate level. It required definitive intervention needed within hours. The profile 2 is a progressive decline in the patient with declining function despite interventions. Intravenous inotropic support may be manifest by worsening renal function, nutritional depletion, inability to restore volume balance, that is called sliding on inotropes. Also describe declining status in patient unable to tolerate inotropic therapy. So where the definitive therapy is required within few days. Profile 3 is stable but inotropic dependent. So these are the patient who cannot live without inotrope. Sometimes we keep them like this till transplant. These are the stable but inotropic dependent. This we have to do it in few weeks or few months, because the 1 year mortality is 80% among these patients. The resting symptoms, profile 5 is exertion intolerance, 6 is exertion limited, and 7 is advanced heart failure 3. Here we can consider for transplantation or LVAD. So coming to case 1, I will present the first case. He is 63-year-old woman. He had suffering from dilated cardiomyopathy. So she had come to me 4 years back with heart failure and got admitted, and we treated her for a heart failure. Because she presented within 6 months of heart failure, we didn't want to do anything major therapy for her. We just started on medical management. We done angiogram. Angiogram was normal. All other evaluation is done, and she underwent a cardiopulmonary exercise test. The VO2 max was 16. So usually we don't consider if VO2 max is more than 14. So when the 16, we put her on medical management and sent home. So she was on optimal medical therapy, and over time she improved from severe to moderate, and slowly she was doing well symptomatically. So because she was getting repeated the frequent ventricular ectopics, we advised her to undergo Holter monitoring, which showed multiple VPCs, frequent VPCs, and also the ill-sustained ventricular tachycardia. So because of this reason, we advised her to undergo ICD implantation, but she refused to undergo ICD because she felt she's asymptomatic, much better than before, and also moreover, she did not want to have any device in her body. So we tried to convince, but we could not. So she was put on medical management. She was also put on amiodarone, beta blockers, and everything, and she was sent home. So she was doing well, almost like 1.5 to 2 years, and she was attending a regular heart failure clinic, and also she was under follow-up of heart failure nurse. So on the day of event, she had come to our pharmacy to buy some medicines, and when she was waiting in the waiting lounge, one of the security guard noticed that she was falling into one side, and he alerted the Code Blue, and immediately our Code Blue team went and resuscitated her, and she was intubated, and he was referred to cardiology department for further management. When we saw her, she was unconscious, and she had hypertension and pressure was just 70 with a high dose of inotropic support, and we decided to put her on IBP support with inotrope. So we started on IBP, we inserted IBP, and she was the BP slightly improved, and but still there is no output. But over time, over 6 hours, she deteriorated a little bit. So we have done echo. Echo showed dilated chambers with severe lead dysfunction, EF 15%, and normal RV function. Despite all this effort, our blood pressure continued to deteriorate. So we kept on increasing inotrope, but the PP was coming down. Further, her lactates started increasing, and there's no urine output. Just when things are looking a bit bleak, so she regained her consciousness. That was a good thing. Otherwise, it's difficult to take any major decision because she was resuscitated little outside ICU. So she was not showing any sign of hemodynamic improvement, and she was sliding on inotrope. So she is a known case of cardiomyopathy. We have seen her for last 4 years. We have followed her up. So we thought in that point of time, if she is not recovering, she may have to undergo transplant. So we didn't want to put an ECMO in this situation because if transplant is required, we may have to keep her for longer period for recovery or for transplant. So it is bridge to decision. Basically, we decided to put a CentriMag. So we want to put a midterm short circulatory support. So patient underwent left ventricular assist device, the CentriMag device, which is implanted on emergency basis, and heart function was normal. And she, after adjusting the LVAD, we usually use a TE to adjust LVAD function. And she recovered post-operatively and extubated on second post-operative day. Respiratory started correcting, liver enzyme showed reduction, inotrope stopped, and we have done 48 hours of CRRT, and we started pouring urine, and we stopped that also. So she was mobilized and started walking twice a day and spending time watching TV, family, and was shifted to private ward. We were not sure about her complete recovery, so we are still not sure, but we thought of registering her for transplant because difficult to get organ in the last minute. So she was registered for transplant. After 1 month of circulatory support, her heart started showing some recovery. So in 15 days, the patient showed complete recovery. So heart became again back to her original state, 40% EF, ejection fraction. So she showed good recovery after decannulation, and she was left with a heart failure rehab team for nearly 15 days for a complete recovery. And because she had that event, probably we thought she had ventricular tachycardia, ventricular fibrillation. That's the one pushed her to this situation. So we advised her ICD implantation. This time she agreed, and we have implanted ICD for this patient. After a year of her falling sick and subsequent recovery, we have done a repeat CPAT, and VO2 max is 18, and EF remain at 40%, and she is doing well, coming for regular follow-up and our heart failure clinic. So this is a fun case, and I'll be presenting the second case. This is 23-year-old man was brought to hospital. The history was very, very short. Basically, he participated in one of the religious function, and the whole night he was there. And next day morning when he came home, he had fever. So patient had fever for some time, and for 24 hours they were giving some paracetamol. I spoke to their family physician. They told to give some paracetamol. But as per their family, what they gave history, after 24 hours, he was not able to walk. So he was taken to nearby nursing home. When he went there, he was very sick, and when he was waiting for doctor, he had one giddiness and he collapsed. So they found him in a ventricular tachycardia. So he was shocked and sent to our hospital for further management. Here, when he came to our emergency, we intubated him. He was getting frequent ventricular tachycardia, so we were shocked many times. On examination, it was found out that patient was in cardiogenic shock and he was getting frequent ventricular tachycardia. So we have done echo. It showed global hypokinesia of LV, and also there is a RV and LV dysfunction. So we have done TROP-I. It is grossly elevated. ECG showed non-specific HEG changes and sinus tachycardia. So tentatively, we made a diagnosis of viral myocarditis, query gain cell myocarditis. So after provisional diagnosis, IABP was initiated on the patient, and he was treated with amiodarone, esmolol, xylocard infusion as antiarrhythmic. Basically, it's not together. It's all started one by one because we were not able to control ventricular tachycardia, ventricular fibrillation. So patient basically provided standard heart failure therapy. In spite of all this, you're still getting frequent VT, VFib, and had cardiac arrest twice. So in this situation, we thought you may have to put on some sort of ventricular support, hemodynamic support. So overall, in a span of 6 to 8 hours, he was shocked 50 to 60 times. He was frequently getting VT and VFib in spite of 3 antiarrhythmic drug infusion. So we decided to put him on biventricular support. So we had the decision between ECMO and biventricular support because he was getting frequent malignant ventricular arrhythmia. So to run ECMO, we need sinus rhythm. So it is not possible to maintain. Again, I had to shock him. So once we put biventricular support, even if he's in ventricular fibrillation, you need not worry about that. So that's why we decided to put him on biventricular support. So this patient underwent biventricular support, both LVAD and RVAD, using CentriMag device. And there was no output because already 6 hours, BP was low. So we started CRRT as a renal replacement therapy post-operatively. Soon, all inotropes and antiarrhythmic infusions were stopped. Once deloaded the heart, all arrhythmia stopped because it was in biventricular support. The BP improved, so we stopped all inotrope. So his acidosis started improving. Kidney started functioning after 1 day because he's a young boy, so everything started functioning immediately. So arrhythmia completely stopped. Heart started improving after 20 days. Patient was decannulated and discharged with good function after 30 days. So this is basically for myocarditis. We have done a biopsy on this boy, endomyocardial biopsy. So it did not show gain cell myocarditis. Initially, I thought it was a gain cell myocarditis because the way is presented and there's so malignant arrhythmia. Then there was no gain cell myocarditis. And we have done all viral markers like Coxsackie virus and everything. All viral markers came negative. I think Dr. Ravi Shetty has shown VAD patient. This is not that patient, is somebody else. I thought if somebody is not seeing VAD patient, you can just see the video of this. This is also a very sick patient. We subsequently underwent transplant, is on biventricular support. So it is within 1 week of and subsequently was able to walk around. So nearly after 1 month, we have done transplant for him. Thank you.
Thank you so much, sir. So we will open to the question and answer session.
Yeah.
So we have a few questions coming in. The first question is to Dr. Ravi Shetty. What size of catheter is being used for LV vent via transeptal approach?
Yeah, for the LV vent, normally when whatever cannula you put for CentriMag, if you're doing a central cannulation, the same, can you hear me? The same cannula can be used. We use an Edwards, like it's a venous cannula. 24 French Edwards venous cannula can be used, which can be bent to any size. Edwards cannula is used for cannulating. It's not an arterial cannula; it's a venous cannula which is put to the LV venting.
Okay.
It is for LV venting, or if you're using a CentriMag for LV apex and iota, to bypass the LV, of the same cannula can be used. So it depends on because we use a bend tip wire reinforced cannula, so that you can, different patients have different size LV. And one more thing is, for venting you use this cannula, and again, if you're cannulating the LV for a CentriMag or an LA, it depends on the diagnosis. Supposing it's a restrictive cardiomyopathy, don't put an LV cannula, put an LA cannula, because it will cause again frequent arrhythmias.
Okay, sir. Sir, one more question from Dr. Dhruva Sharma from SMS Jaipur. It's for Dr. Ravi Shetty. Any experience on using roller pump as temporary MCS? And if yes, for how long?
No, I don't think so. We should use it unless post cardiac surgery or something. You can keep them for 1 or 2 hours. Otherwise, it's going to cause a lot of damage to the blood, and so it is ideal if you think the heart is not going to recover, to put on some form of centrifugal pump. It's better.
Yeah. If you make arrangement for your device and get it ready and keep it ready, you can use it.
So some hospitals don't have an ECMO also. They can, some people hire ECMO or CentriMag can be hired. In such situation, you can put them on a bypass machine. Keep them on bypass machine, and then once these devices come to your hospital, then only you can ship them to these devices. So ideally, if you are thinking of recovery early, you can, and you require biventricular support, you can put on ECMO. Otherwise, CentriMag is a better pump.
Okay. Thank you, sir. So one question from Dr. Debashish Das from NH. This is to Dr. Nagmalesh. How often, in patients on ECMO waiting for transplant, if we do sternotomy for LV vent, is that a deterrent for transplant?
No. See, putting LV vent is not deterrent for transplant. The only issue is what we have seen in our experience. If you are putting ECMO for transplant, you have to do very early. Like within 10 days, if you are doing transplant, then you can keep waiting on ECMO. Because even in allocation, ECMO is considered as first, then LVAD. See, very difficult to wait in our country on ECMO. So I feel it is preferred to put them on VAD if you are not able to wean them off from the ECMO within 1 week, and then let them wait them on VAD. If you keep them on ECMO for transplant, they'll have hemolysis, infection, they are on the bed and they can't mobilize him. So the post-transplant outcome is quite bad compared to CentriMag. So that's the reason we try to discourage. But if somebody on ECMO, you got the heart immediately, you can do it. So vent is not a contraindication or any deterrent for doing transplant. Anyway, you are removing the heart.
Okay. The question is from Dr. Praveen Kulkarni. Any difference in incidence of hemolysis between ECMO and CentriMag?
Yeah, a lot of difference. See, ECMOs, frequently we see hemolysis, but unless there is some problem with the implantation or running the pump, there will not be any hemolysis with the CentriMag. See, one patient we run CentriMag for 215 days, almost like six plus months. So there is no hemolysis. So if you manage well, for all our patients, there is no hemolysis. Infection also very, very less. So one thing is thrombus formation, especially when you have a RVAD. RVAD, because it's a slow circulatory system, you can have thrombus in the RVAD. That we should be carefully seeing and manage.
So what we have to understand here is the difference between a CentriMag and ECMO circuit is ECMO has an oxygenator. So it is more damaging to the blood products. So unless the patient's lung is bad, if we will need a ECMO support, or if it is a biventricular support, putting two pumps in a CentriMag if it's if you patient can't afford, and if you're going to get a heart soon, you can put an ECMO. So otherwise, there's going to be more hemolysis or more damage to the blood products if there's ECMO because of the oxygenator.
Yeah.
And even the pump of CentriMag compared to Mac pump is superior. CentriMag pump is more superior and more long-lasting, more hemocompatible.
Yes.
And for example, if you want to give flows, the rotations will be less in a CentriMag pump compared to the ECMO pump. Both are centrifugal pump, but the rotation are less, so less damage to the blood products also, as with the pump. And because of the extra oxygenator in the ECMO, it is going to cause more damage.
See, this CentriMag is a magnetically levelated pump. So where these structures, whatever the pump, it will not touch each other. So the production of heat is much lesser than compared to ECMO. So that will prevent, injury to blood and hemolysis. So in our opinion, CentriMag is better than ECMO.
Thank you, sir. Sir, there is one question from Dr. Kaushik Sheth. Have you come across any malignancies as a cause of refractory LV dysfunction?
Malignancy of what?
The question says, have you come across malignancies as a cause of refractory LV dysfunction?
See, that is possible because, see, one of the cause for heart failure is chemotherapy. So chemotherapy induced cardiomyopathy is very common. So we have seen a lot of patients who come for chemotherapy. They developed cardiomyopathy and LV dysfunction, RV dysfunction. They come for therapy. So in this situation, so very difficult to decide unless you speak to your oncologist about their long-term survival, and then we can decide what device therapy we can put. So usually within 5 years, we don't advise them to undergo transplant. So especially lymphoblastic carcinomas, leukemias. So these are very common post-transplant. So if you are doing transplant on this patient, so they may very high chance of developing recurrence of cancer. So we don't do transplant. So we keep seeing advanced heart failure even among cancer patients who undergo chemotherapy.
Okay, sir. Thank you so much. There is one question by Dr. Karthik Vasudevan. In post-MI, post-PCI, refractory cardiogenic shock, do you prefer ECMO or CentriMag?
Yeah, so in this situation, the best device to put is Impella in post-MI cardiogenic shock. But as Dr. Ravi Shetty said, it is very expensive device to use it. In our center, we use ECMO as for the bridge to recovery. So we have done a lot of ECMO post MI, or we have seen a good recovery because they require very short term. But you should choose the right patient. The person who comes to hospital after QRBB MI after 1 week, if you put ECMO, you don't know what we are going to do it with this patient. So in this situation, when you are sure that the LV is completely damaged, I don't use ECMO. Even if I use ECMO, probably once I'm sure it's totally damaged, I'll convert it into CentriMag, and probably I keep him for a longer period, either for recovery or transplant. But if you are sure for recovery, I've seen sometimes having inferior MI, cardiogenic shock and not responding. Even if you put IVP is not responding. This type of situations, you put ECMO and within 4-5 days, it starts showing recovery. And one more situation where patient gets refractory arrhythmias, VT, VFib. In this situation also, when we have put ECMO and they have very good results, and immediately this arrhythmia stops and they start recovering. So basically, I'll tell you the best thing to do is tandem heart. So if I have a next patient, I'll do tandem heart. Tandem heart is basically you do a septal puncture, you put a cannula to the LA, and that is inlet cannula, and outlet cannula to the aorta. Both can be done percutaneously. and you connect this to CentriMag. So this can support very nicely if patient does not require oxygenator. If oxygenator is required, ECMO is best. If oxygenator is not required, just a cardiac shock and oxygen saturation is normal, and better to put a tandem heart. I think all of us in Indians can do a septal puncture, so very easy to do tandem heart.
Thank you, sir. There are quite a few questions coming in. So this question is from Dr. Mrunlendu Das from Kolkata. Can we use a graft in femoral artery and cannulate in ECMO so that distal perfusion is taken care of?
Yeah, you can do that. The problem with that is it will keep oozing. What happens is, or you have to take some pleasure stitches and suture the graft to the femoral artery. But what we have seen is it keeps oozing. You have to keep changing the dressing. Actually, you get if you're doing a surgical cannulation, you can just make a small incision and take a purse string and first put the distal cannula and then put the proximal cannula. If you put the graft, the problem is the graft will start oozing, and about by a week, the wound can get infected. So that's the issue with putting a graft, and especially if it's a new graft, it's still better. But what we do is we suture in 8 mm graft. Again, the left out we sterilize and get it back and reuse it. Then what happens is it's surely going to ooze very badly. If it's a new graft, it's still better.
Actually, initially we tried all this. We used to graft and put it, especially post MI. We used to have very severe bleeding and very difficult to manage. Then we switched over to percutaneous method. So the bleeding is the issue with grafting. Otherwise, it's very nice actually. So there's no distal vessel problem. But you can always put a distal cannula for a perfusion. So
see, I would suggest if you're putting a graft, don't put the venous cannula in the same leg. What we have seen and the study shown, we do minimal invasive. See what happens. You put a graft. What happens? There's lot of flow to the leg, and what happens when you put a venous cannula? The venous return is occluded, so you can result in gangrene of the leg because of venous occlusion. So I would suggest. Normally people put and get away. I would suggest you put the venous cannula in the other leg if you're putting the graft. Even for ECMO or even if you're doing some form of surgery, cardiac surgery for 4-5 hours won't make a difference. But otherwise, it's safer to put the venous cannula. What we do normally is even venous cannula is put percutaneously. Even if you're doing cardiac surgery, anesthetist puts the venous cannula before surgery. If you're doing peripheral cannulation, so it is all done percutaneously. So especially after, as Dr. Nagmalesh told, after a post-MI case, they were given so many antiplatelets and all loading doses and all sort of thing. It looks like a very small incision. It can ooze. So you have to be very careful. Make a very small incision, even if you take a purse string and do. The problem with percutaneous is again when we close, we have seen the vessel gets a little bit ragged and damaged. We'll have to do some form of repair. Sometimes we'll have to do a repair. So there's a balance between both.
Thank you, sir. So, the next question is Dr. Amit Sharma from Mumbai. This is to Dr. Nagmalesh. Would you recommend IABP support in myocarditis like in this patient?
Yes. You see, in this case also we put IABP as a first line. So always you should start with IABP unless you are sure that it's not going to work. Initially we thought it's going to work because you are not getting so much arrhythmia. You had only twice you had VT and Delvious severe lead dysfunction. That's the reason we started IABP. But on IABP it started going down, and basically recurrent VT we feel we could not manage. That's the reason we put a biventricular support. Even ECMO is not possible in this case because when you require hemodynamic support for arrhythmia. So you need a biventricular stable support. So you can't put a ECMO, as I told you earlier.
Okay. Dr. Dhananjay Malankar, he's asking, does LV apex cannulation hamper its potential for recovery in LVAD places for myocarditis or for some reversible cause?
No, LV apex, so many of us do LV apex de-airing, and LV apex venting is not, the LV will recover completely. That doesn't cause any damage to the heart. It's a very, it doesn't cause any damage to the heart. We almost for all the cases of, biventricular support, we put or LVAD patients, we put a LV cannula. Most of the time, unless, as I told you, it's restrictive cardiomyopathy, and cannula is going to touch the ventricle and cause arrhythmias. We think of LA cannulation.
Yeah.
Even if the heart will recover, this lady who recovered, hers was LV cannulation.
See, you can put LA cannulation, but chances of stroke is very high because the LV is not will be deloaded, so they can get
Clot can form.
clot, and they can cause stroke. The other problem is in case of restrictive cardiomyopathy, what Ravi said, if you put LV cannula in case of restrictive cardiomyopathy, because the LV cavity is very small, so you put a cannula and the suck from LV, it can cause a suck down effect. So it will stop draining because the LV cavity will become very, very small. The both walls start touching each other. Then there will not be any drainage. So that's the reason you should put LA cannulation in case of restrictive cardiomyopathy.
So the question next is from Dr. Manoj Durairaj. Any technical know-how on how to perform transeptal venting of LA continuously, wire the cannulae, etc.? So any suggestions on that?
Transeptal venting of the LA, is it?
Of LA, yeah.
No, it's same above the right superior pulmonary vein. You take, what we do is for all these cannulations, we take double pulse string and snare it, and then you tie it there and leave it. We don't put a mosquito when we close the chest inside. We tie it to something like a button. If you take a suit button, take both the limbs of the suture across, and I forgot to put that slide. Tie it over the button, and you fold it and tie it and put it inside the sternum. It's just above the right superior pulmonary vein, like how you went normal cardiac surgery. Manoj, you can do that. There's nothing special.
Yeah. And one more question to Dr. Shetty is from Manoranjan Mishra, Hiranandani. Is it advisable to use IABP along with Centrimag ECMO to make it as a pulsatile flow in cardiogenic shock patients?
No, I don't think so. In Centrimag you'll need it, but some studies are saying in ECMO it unloads the LV, but whenever we have used it's not proven. There are conflicting views on IABP with ECMO, because when you put a peripheral ECMO, LV is not unloaded. They say IABP helps, but the ECMO is perfusing peripherally if it is a peripheral cannula, and your IABP is opening and balloon is closing. If it's all not properly opening, timing is not good, it can cause more damage than help.
Yeah, basically, in case of post MI, usually you have IABP placed before we doing ECMO. It's all the step by step. So in this situation, what we do is we'll just leave that IABP for time being till we have a better hemodynamic support control. Because what happens in case of ECMO, which increase the peripheral vascular resistance, IABP will reduce peripheral vascular resistance, and thereby it will compensate to some extent. So we leave IABP for some time, and but the problem is the hemolysis. Yeah, one side ECMO is running, other side IABP is there. Both put together is caused a lot of hemolysis. So after 24-48 hours, we don't keep, we'll just remove it. Even though hemodynamically it's helpful, but very difficult to manage. So if patient is stable after 24 hours, I prefer to remove it, or 24, 48 hours.
What I'd like to add is once we go on ECMO, we should see the BP won't hold initially. So don't get panic. Give a lot of volume. You'll think the professional will tell the patient is leading a lot of volume. You're not holding. BP is not holding. So what happens? Sometimes the SVR can drop, and you have to give volume, and you have to manage first 1.5 hours. Then slowly things will stabilize, and there'll be some bleeding also if you've done a sternotomy, and all that will add up. So what we do is before putting an ECMO, for example, not post MI, if after a cardiac surgery or after transplant, we almost correct the protein fully, and then we put on a ECMO, and almost full correction is done, and then we keep everything ready for ECMO, and then just go on ECMO. We don't connect the ECMO and give protein because ECMO circuit can clog, or it's not that because we are going on ECMO, we don't give protamine. We do full correction. Otherwise, it is going to be disaster. It's going to bleed, especially in post-transplant cases.
Okay, sir, one interesting question. There's no name in this, but then, yeah. In today's scenario of restriction of movements, including organs, do you feel Centrimag would give better survival possibilities to advanced heart failure patients as a bridge to transplant?
No, I don't. I don't prefer now Centrimag because see, it is preferred to do transplant in 30 days or 35 days or 40 days. So more than that, you have escalating incidence of complications. Either infection is less, but usually thromboembolic phenomena, bleeding, clots, all this can happen. So we are not sure about availability of heart at present. So I don't prefer Centrimag at this point of time. If RV is good, probably HeartMate is a better choice because you can go on for 6 months or 1 year and come back for the transplant at later date.
See, what happens in our country is HeartMate or durable VAD is expensive. That's why we are resorting to Centrimag. Otherwise, if RV is good, HeartMate is much or a durable VAD, whatever you're using is much better than Centrimag. Centrimag after 30 days, there's more chance of clotting and all that is there. So it's not even approved for such long use. Luckily, we've been lucky. That's all. Otherwise,
see, I have one patient who's waiting for transplant. Yesterday, he came with generalized weakness, and I was, just kept for observation. And he had a VT, he had a cardiac arrest, resuscitated. We have put him on, IABP, inotropes, and today is fine after 48 hours. So the family is asking, I don't know what to do now. I prefer to bring him out of this and keep him back to the same situation than putting him VAD now, because after putting VAD, I'm not sure getting heart for next 2-3 months. So,
because of the COVID,
yeah,
we don't know whether we'll be doing transplants soon.
So that's the reason I'm trying to manage him medically so that I can bring him out of this situation. If you don't have option, we can explain to the relatives and put, but availability of organ is a big issue. Especially if you're putting first time, managing for long term will become a big issue.
Sir, can you please tell the longest duration for IABP, ECMO, and Centrimag respectively?
IABP we are used for 2 weeks, 2 to 3 weeks. Okay, and ECMO, VA ECMO we used 3 weeks. And VV ECMO you use 2 months, that is 60 days. And biventricular support, BiVAD, Centrimag, we use 215 days. Probably it's the longest. We are just searching anybody else use such a long period because it's approved for 1 month. So I use for 6 months because multiple issues, not getting heart, and the too many people in Bangalore are waiting with VAD for heart with the same blood group. So we got into that situation. So you waited for 215 days.
Okay. Sir, this question again is for Dr. Ravi Shetty. Last 2 questions we are taking, sir. The patient in Intermax 1 or 2 requiring LV support immediately before shifting to OT for LVAD. Will most patients be started on ECMO to buy some time? Dr. Shanmuga Sundaram.
No, if we are, thinking of, putting on Centrimag, we'll never put on ECMO. It is Centrimag, to install a Centrimag, it is not a difficult thing. It's just a routine cannulation. Any cardiac surgeon can just take him to do a sternotomy, put a purse string into the aorta and the LV apex. And technically, I myself, in our unit, I don't even put pleated stitches to the LV and aorta now because one case we had a lot of infection after doing a transplant, after putting Centrimag and doing a transplant. And second thing is when we wait for long, that 213 days patient, it was like, you inside the heart, you put cement and close the chest. My two scissors bent to open the dissecting the, I'm not talking about sternum, I'm talking about dissecting the heart to remove the heart. It becomes lead, it becomes plastered. So to put a Centrimag, it is just routine. You don't have to go on bypass. Just do cannulation within, after the shifting into the OT within 20-25 minutes, you can be on Centrimag. So don't go on bypass or don't go on ECMO. Again, go on bypass. There's chance of all this, blood products usage and it becomes sensitized to do transplant. Just put cannula to the aorta and LV apex. It is very simple.
But only one situation you have to put ECMO. What Ravi said is right. Is do only quickly. 25 minutes they'll finish the cannulation. But only one situation, if patient is not maintaining saturation, patient is bad pulmonary edema, then you have to initially stabilize him with ECMO and then put a VAD.
No, that is also, again, if you're suspecting there's a lung cause. Otherwise, once you deload the ventricle and he's on ventilator, for a couple of days he'll recover.
If it's lung issue, you can go for ECMO, then you can do it, you can do VAD later then.
Then after a couple of days, if you are suspecting lung issue, then fine. If you are thinking the lung pulmonary edema is because of the heart, then just put Centrimag and come out. That will be better. And the Centrimag and all this, more than 30 days, it has its own complication of thrombosis and infection. Any invasive procedure, we've been lucky. We had only one infection, but it will be very sad to lose a patient after transplant goes on well because of sepsis or infection.
Okay, sir, can we take one more question? I think it's again from Dr. Manoj Durairaj. What is anticoagulation protocol for Centrimag long term?
We maintain a ACT of around 200, 220. Initially, when we, as I told you, we after transplant also we give, we see the RV is not recovered or anything. No, after transplant we put a ECMO, but otherwise for Centrimag patients, normally 180, 200. That's all. The problem with Centrimag is the right side, which we have put BiVAD. The clots start forming almost after 25-30 days near the connectors. Venous cannula and the Centrimag circuit connectors, clot starts forming. Even if the clot, you see initial white strings and then red blood clots, what you have to do is get everything ready, give a little more heparin. Now the patient's chest is closed and he's not bleeding, your ICD is out. You give little more heparin, almost a little around 300 ACT, clamp both the lines, and you have to come off the circuit and put it within 3 to 5 minutes, connect back. So otherwise every day, first few days ACT is about 180, 200. Then we put them on warfarin. We put on warfarin and maintain INR around 2.25, 2.5. And if you are planning to do a transplant, if you are first if you're sure you're going to get the hearts, give vitamin K before. And then again in the OT, give vitamin K injections. Then you'll have to be ready with 2 platelets and a lot of FFPs. See, when you're doing Centrimag and transplant, we have, including platelets, FFPs, sometimes we have transferred even 70 units of blood. So it's not a straightforward procedure. It looks
we
like
keep one load of products when we are doing post this one. Somehow we evolved ourselves how to manage this bleeding issue post
bleeding
transplant.
issue.
It is hell actually. Post VAD, if you're doing transplant, you should
And
have so much.
we irradiate the red bloods. I don't know how useful it is, but
Still we do it.
we still do irradiation of the red blood cells for to prevent.
Okay. Sir, I think, the last question for the evening. I'm sure there are many participants who are waiting for more answers. There are quite a number of questions which are flowing in, but keeping in view of the time constraint, we are just taking the last question. This is from Dr. Manoranjan Mishra. Do you put Centrimag centrally or peripherally post PTCA cardiogenic shock? What is more beneficial?
Centrimag can't be put peripherally except the one I told you, the Takeda procedure, which we have not done as for now, where you put, what the Centrimag, what my colleagues in NH have done is they have done, Dr. Bhagirath, what he has done is put created an ASD. He's put an cannula, that is again wire reinforced venous cannula Edwards from the femoral vein multi-hole into the LA, and they have holes in the LA. I mean the cannula is in the LA and the RA. So it drains both the LA and RA. So the blood is unloading the left ventricle by draining the LA, and it's unloading the right ventricle by draining the RA. And it is like a ECMO. It is connected to a Centrimag and then connected to ECMO and returned back to the patient. That's how they have unloaded the left ventricle and right ventricle. That they have done. Otherwise, what we have to do is the Takeda procedure, which I think is a very interesting procedure. Venous cannulation, artery, peripheral cannulation, femoral vein, femoral artery. Connect a Y connector, make a small thoracotomy, LV apex cannulation, and then put a Y connector, and initially as ECMO and then as LVAD it can be changed, as I had shown earlier. So that's how Centrimag. Otherwise, Centrimag can't be used peripherally. Normal position, normal situations. Unless you can use a Centrimag pump instead of an ECMO pump. That's all.
Yeah.
Then that will work out expensive because you are using the ECMO circuit. You are using whichever ECMO oxygenator, everything, which comes integrated with the pump, or you can use separate. It will work out expensive to use a Centrimag pump in ECMO circuit. The finance is not an issue. It is more of a hemocompatible, the Centrimag pump. You can use it. That's better.
Money is not an issue. You can use that.
Fine. So, thanks a lot, sir. So, shall we are closing the question and answer session. Once again, on behalf of Abbott, we sincerely thank all the delegates who are part of this webinar and making it so lively with so many questions and making it interactive. We profusely thank Dr. Nagmalesh and Dr. Ravi Shetty for their wonderful insights on this topic and patiently answering all the questions on both short-term MCS as well as cardiogenic shock strategies and the protocols. And I think it's a wonderful example of a team-based managing patients successfully in centers like MSR Narayan Hrudayalaya. We once again thank both the speakers and also all the delegates, the Abbott team for coordinating for the entire webinar. And we look forward for more such kind of interactions. Sir. Thank you so much.
Thank you.